Thank you, Dr. Gleave. I'm Drew, one of the first-year residents. Today I'll be talking about severe infections of the upper GU tract, mainly Emphysematous Pyelonephritis and Xanthogranulomatous Pyelonephritis. The objectives for today will be to describe Emphysematous pyelo and Xanthogranulomatous Pyelonephritis, what it is, how it happens, and then to discuss some of the treatment options and approach considerations through literature search. So I'll start off with emphysematous pyelonephritis. It's a rare form of pyelonephritis caused by gas-forming organisms. The gas forms within the renal collecting system in pretty well every case, with extension into the renal parenchyma and potentially perinephric tissue as well. The typical pathogens that you'll culture, either from the urine or the bloodstream, will be E. coli and Klebsiella mainly, but can have Proteus, Enterococcus, Pseudomonas, Clostridium, and Candida has been seen to do this as well. Typically, these types of infections are in patients with poor diabetic control, type 2 diabetes, or those who are immunocompromised. It has been reported in transplanted kidneys as well. But the main driver seems to be poor glycemic control. It's more commonly found in women with a predisposition of about 3 to 1, but some sources say as high as 6 to 1, being more common in women, possibly due to the higher rates of UTIs in women, but unsure whether that is exactly the case or whether there's something else going on. This is a paper from 2000 that just shows some of the patient characteristics, presenting complaints and lab data. This was a series on about 60 patients. Clinical symptoms on presentation, primarily fever and flank pain, typical kind of pyelonephritis picture. Other things would be acute renal impairment. Hemoglobin A1C was seen to be elevated in 72% of the patients that they looked at, but other literature will be as high as 90%. Leukocytosis, thrombocytopenia, and then pyuria are the other kind of most common things that you'll see on lab data. In terms of setup for failure or poor outcomes, thrombocytopenia, acute renal impairment, altered level of consciousness, and shock seem to be the most predictive of mortality based on this series. 89% of the people who passed away with emphysematous pyelonephritis seem to have thrombocytopenia, with smaller values here for smaller values here for these other clinical scenarios. I note the actual extent of the diabetes here, retinopathy, sort of end organ dysfunction, didn't seem to have a significant impact on outcome. We'll talk a little bit more about that later. So for why these people present with gas within the collecting system is poorly understood. It's thought to be due to elevated glucose levels within the tissue. Patients will also have some vascular compromise impacting the immune cell delivery to the system, as well as clearance of toxins. It's thought that the hyperglycemia provides a favorable microenvironment for these gas-producing bacteria and their fermentation. It was first described back in 1898. This was a paper published by Kelly and McCallum. They talked about a woman who was actually quite young. I think she was 36 years old, had a year's worth of symptoms, malaise and intermittent fever, presented and had cystoscopy, and when they did their physical exam, they found a large kidney, and on cystoscopy were able to identify gas and pus coming from the right ureteric orifice when they manually palpated over the kidney. So they talked about pneumaturia and how there's 3 types, the first being found after instrumentation, second being with fistulization with bowel, and the third being this kind of unknown entity coming from within the collecting system itself. It was later characterized in 1962 after another 11 cases were reported, so this is almost 60 years later, described by Schultz and Chlorfine. They coined the term emphysematous pyelonephritis, and this was the first set of authors to really emphasize the relationship between the infectious process and gas formation that was identified on the history and X-ray that they used then. In terms of classifying these types of infections, the first classification system was set up by Wan and colleagues. They wanted to figure out whether there was any way to predict mortality based on the radiographic findings. It was a retrospective study with only 38 patients. They described type 1 as the most brutal type of infection with greater than 1/3 renal parenchymal necrosis, absence of fluid-filled collections, or the presence of streaky mottled gas pattern. And it carried a 70% mortality if you had these characteristics on imaging. The type 2 is less than 1/3 renal parenchymal necrosis with the presence of renal or perirenal fluid and a bubbly gas pattern or gas within the collecting system. And this carried a 20% mortality. Here's just a couple of pictures of some emphysematous pyelonephritis. On the left, you'll see the right kidney is, well, you can't see the right kidney. It's pretty awful looking. Gas around the kidney here. You can see Gerota's fascia here. This is all perinephric. I assume this is the kidney here, but really it's a lot of necrosis of the kidney there. On the right-hand side, again, you'll see emphysematous pyelonephritis. This is actually a case of bilateral pyelo. On the left kidney, gas seen within the collecting system as well as in the renal parenchyma here, and on the right-hand side, peripherally in the renal parenchyma. That classification system is kind of convoluted and difficult to really follow clinically, so Huang and colleagues devised a new stratification system based on CT findings. They looked at 48 cases over the time period of 89 to 97, and they kind of took a more anatomical approach, which was a lot easier to follow. So class 1 being gas only within the collecting system. Class 2, gas in the renal parenchyma without any involvement of the extrarenal space. Class 3A is extension beyond the perinephric space, and Class 3B, gas in the pararenal space or involving other adjacent structures. Class 4 defined as bilateral or emphysematous pyelo in a solitary kidney. Here's the results from their series. They compared their classification system with Wan and colleagues. They found that the highest mortality was in the class 4, emphysematous pyelo in a solitary kidney or bilateral, which is not surprising. Mortality kind of increased from class 1 to class 3, and in class 3, type A had a higher mortality. Now this was without extension from the perirenal space, and thought to be due to inability to drain percutaneously, which we'll get to in a second. And you can see their data kind of supported the previous classification system as well, with type 1 being worse, having worse outcomes for patients. So how do we treat these patients with emphysematous pyelo? Many approaches have been done in the history. People think, let's try just antibiotics, conservative measures. With only 5 patients seen in this case series of Huang et al., carried a 40% mortality with strictly antibiotics and resuscitation. Proceeding to direct nephrectomy or emergency nephrectomy led to actually pretty good outcomes, but only 2 patients had this. No mortality in these 2. Percutaneous drainage was quite well accepted, and only 15% mortality, and those who had percutaneous drainage failure, this value here, 1 out of 8, should actually be 7 out of 8. Only one person had mortality outcome after a delayed nephrectomy after failing percutaneous drainage. So we'll talk more about percutaneous drainage in this setting. There's a meta-analysis done in 2008 investigating the treatment options for emphysematous pyelo, what the best real treatment timeline looks like. This contained 10 studies with 210 patients from 1966 to 2006. In this series, they found medical management alone led to a 50% mortality. Emergency nephrectomy with medical management, 25% mortality. Refusing treatment was universally not a good idea, with both patients who refused treatment passing. And percutaneous drainage with medical management, 13.5% mortality. And then failing that, moving to elective nephrectomy after medical stabilization had a better outcome still. So kind of a stepwise progression in terms of patient outcomes there. Second meta-analysis done after this study was published in 2014. This was in the Arab Journal of Urology. Looked at 32 papers from a 30-year period, much more kind of modern in the papers that they looked at. 628 patients were within this cohort. So they looked at, again, emergency nephrectomy, percutaneous drainage, medical management only. OD is open drainage, percutaneous drainage by, and then delayed nephrectomy, and medical management by delayed nephrectomy. Again, you can see emergency nephrectomy was actually quite bad for patient outcomes. Percutaneous drainage was better still, and then percutaneous drainage followed by delayed nephrectomy had the best outcomes there. Directly comparing one treatment modality to another, percutaneous drainage seemed to win out over emergency nephrectomy with an odds ratio of 3.1. And emergency nephrectomy versus medical management alone, medical management was the better option, sort of letting these patients stabilize before performing any type of surgery. Percutaneous drainage and delayed nephrectomy seemed to be the sort of best option that they had in this case series, with an odds ratio of 0.2, meaning if you can succeed with percutaneous drainage, push the nephrectomy down the road, those patients seem to do much better than those who had emergency crash nephrectomies. I'm not sure it's entirely surprising, as the patients who were receiving these emergency nephrectomies were typically the patients who were crashing on medical management or initial resuscitation. No difference in percutaneous versus open drainage, and
You're talking about drainage only if there's obstruction.
Of perinephric collections or evidence of obstruction. So drainage of abscesses around the collecting system or the perinephric space. Mm-hmm. This case series or meta-analysis looked at whether diabetes had any impact on the outcome of patients, and there was no significant difference between whether you had diabetes or not. It was typically the glycemic control that had more impact on mortality. Going back to the previous sort of demographic slide, I had talked about presence of shock meant poor outcomes, and these patients who were crashing typically did not do so well compared to those who were more stabilized. So early resuscitation is key for survival. comparing the percutaneous drainage and emergency nephrectomy, you can see that all these studies together, none of them really had much in terms of significant results, but when taken as a group, there may be an increased survival benefit for percutaneous drainage versus emergency nephrectomy with an odds ratio of 2.5. And here, medical management versus emergency nephrectomy. Medical management did slightly better, like odds ratio of 2 compared to emergency nephrectomy when taken as a whole, but you can see that all the case series didn't really have much significance on their own. So when doing an emergency nephrectomy for these patients, if they failed medical management, percutaneous drainage of either the collecting system or perinephric abscess, what do you do with the ureter? This is a case that was reported in 2015 with emphysematous pyelonephritis and proximal ureteric gas. The gas extended down the proximal ureter to the lower third, and initial medical management with resuscitation antibiotics was undertaken. A rapid clinical decline necessitated early nephrectomy, and when they took out the kidney, they saw frank necrosis of the proximal ureter, requiring ureterectomy as well. They hypothesized that it was likely due to the increased vascular supply at the distal aspect of the ureter, and were able to salvage that. But here's a picture of their case. You can see the gas here and the white arrow around within the renal collecting system on the right side, with gas extending all the way down to the mid-ureter there. The gross specimen, you can see this frankly necrotic ureter here, and so important to take a look at the structure when you're taking out the kidney. For follow-up on these patients, kidney preservation, I guess, is the ideal. If we can keep patients with their kidney without nephrectomizing them, that seems like a good idea. So these guys looked at 30 patients from 2000 to 2010, looking at what kind of outcome they had for their kidney-sparing approach. All patients underwent resuscitation and antibiotic treatment, followed by percutaneous drainage. These are with nephrostomy tubes. Renal preservation was undertaken for patients who had a renogram with function greater than 10% on the affected side. Kidney preservation, they found, was successful in about 60% of their patients, 70% of their patients. Follow-up was difficult, but they did have 13 patients come back for reassessment with a mean time to follow-up of 21 months, which is quite far out, I thought. But the kidney function in the patients that did have follow-up renograms was stable and actually improved in 2 patients. So important to monitor these people's renal function and make sure they don't have any decline, as the necrotic renal parenchyma will cause long-standing damage, and you want to make sure that they have as good kidneys as possible. But reassuring that they had a couple patients with return of or improvement of their kidney function at follow-up. So I think the moral of the story here is that early resuscitation and broad-spectrum antibiotics are key for stabilizing patients, getting their glucose control optimized to reduce that sort of driver of fuel for the bacteria, and then percutaneous drainage, if possible, with nephrostomy tube or perinephric drains, followed by delayed nephrectomy if drainage is unsuccessful, is kind of the treatment approach.
Which antibiotic?
So starting off broad spectrum with something that covers your enteric bacteria, the E. coli, Klebsiella, and then titrate down with your sensitivities from cultures.
Bad. Wouldn't.
I think that would be appropriate. But yeah, I'm not sure. I think probably that would be wise.
What if you have stage 2 where there's gas?
Mm-hmm. Mm-hmm. Yeah, I think in that situation, the studies, they don't really say exactly on the granular level where, like, which class had exactly which procedure. I think it's a clinical decision. They just said in whole, the patients who had percutaneous drainage tended to do better than those who didn't, and so it's not clear.
If there's something physically drained, you've got a few bubbles of gas in the brain.
Mm-hmm. Yeah, and I think that goes back to the mortality around where there's in the class 3A versus 3B, when there's perinephric versus paranephric or extension beyond. The patients who actually had more extensive disease tended to do better, and I think it's because, and the authors think it's because they had a bigger target for drainage, and were more likely to have a successful percutaneous drainage instead of going for an emergency nephrectomy.
I think this underscores like a two on because I've heard from and breakdown.
Mm-hmm.
So like bedridden.
Yeah. And when I get into XGP, there's it is quite common to see fistulization formation between skin, enteric contents, and things like that. So any kind of chronic inflammatory process or prolonged infection will predispose to that. So yeah, that's a good point.
Was there any indication?
Yeah, so I think it's when you have a patient who's crashing on your initial conservative management with broad spectrum antibiotics, fluid resuscitation, electrolyte replacements, and they're still not improving. Percutaneous drainage, if possible, and if they're still deteriorating, then the only kind of option for source control is emergency nephrectomy. But the urgent, okay.
There's no indication.
Based on the research that I was looking at, it seemed like the mortality data was not supportive of that. That initial percutaneous drainage and medical management was better from a mortality standpoint.
The other question is, a lot of these people have
Mm-hmm. 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 I didn't include it in this talk, but there was some research on whether retrograde stenting versus nephrostomy tube drainage was beneficial, and it seemed that the percutaneous drain, for whatever reason, was more effective. And it didn't include that here, but it was one report that I came across. So I'll move on to Xanthogranulomatous Pyelonephritis, or XGP. This is another rare form of chronic pyelonephritis, an inflammatory state of the kidney. It was first described in 1916 by Dr. Schlagenhofer. Unfortunately, when I accessed the journal, it was not in English, so I can't tell you what the exact case presentation was, but that's the date, based on all the literature. Um, Typically, XGP is seen in the context of an obstructing renal calculi with possible staghorn as well. Presents again more commonly in females with 2.5 to 3 to 1 predisposition. Presenting symptoms, again, similar to emphysematous pyelo with fever, flank pain, malaise, anorexia, weight loss, so some nondescript complaints that patients may come to you with. Sometimes you'll palpate physical mass in the flank and commonly can be mistaken for actually a renal mass or a cancerous process. And as mentioned before, fistulas can be seen either cutaneous or with bowel content. What you may find with your initial lab evaluation is anemia, acute kidney injury, and elevated ESR indicating inflammation. Pretty non-specific. Causative microorganisms in this case, again, E. coli is the big player, and Proteus comes second. Pseudomonas enterococcus and Klebsiella also involved. Imaging findings on XJP is classified in stages as well, with stage 1 being disease confined to the renal parenchyma, stage 2 involving the parenchyma and extending to perirenal fat, and then stage 3 extending beyond the perirenal space or diffusely in the retroperitoneum, similar to the classification system for emphysematous pyelo by Huang, with more of an anatomical approach. Findings that you'll see on CT include nephromegaly, calculi in 73% of cases, and staghorn stones in 35. Hydronephrosis, pretty much everybody will have, as it is an obstructive kind of process driving this disease entity. You'll have densities within the renal parenchyma and fluid that measures 110 to 215 Hounsfield units, so more dense than water, with peripheral enhancement of these fluid-filled cavities, which I'll show you in a second. You may see thickening of Gerotis fascia or this kind of perinephric stranding that we hear about all the time. There's a couple of images that I took from Radiopedia. On the left-hand side here, you can see a left kidney with multiple renal calculi, peripheral rim enhancement here in fluid-filled hydronephrotic system. You can see this different density here with the renal parenchyma here. This is a contrast-enhanced study. And then on the right-hand side, you can see this big perinephric abscess here, posteriorly tracking down along the psoas. On microscopic analysis, they describe 3 classic zones, which is centered around the calyx. The innermost zone is filled with necrotic debris, leukocytes, lymphocytes, plasma cells, macrophages, your big inflammatory markers or inflammatory cells, fending off the infection. The middle zone contains a vascular granulation tissue, and you'll see hemorrhage occasionally identified there. This is the zone where you'll hear the classic lipid-laden macrophages. This is kind of the buzzword for XGP. When you hear lipid-laden macrophages, it's almost diagnostic. You hear that in all cases of XGP. And then the outer zone contains these giant cells and cholesterol clefts, which I'll show you. You can actually see grossly as well. So the patient I showed you with those images there, this is their gross pathologic specimen. You can see horrible looking kidney with all this cholesterol here, fat within the renal parenchyma. You can see the stones here and frank pus coming out from one of the renal calyces down here. But horrible looking kidney with very thin parenchyma here, so treatment options for XGP, generally thought of as a surgical problem. Treatment's usually in the form of radical nephrectomy, And it's necessary to manage these patients optimally with antibiotics prior to surgery if at all possible, and prophylactic antibiotics once they're stabilized to ensure they don't have disease recurrence prior to their surgery. This is a case series done in 2009, published 26 patients, 12 undergoing an open approach and 14 laparoscopic. They compared demographics, intra-op and post-op complications, and just in general, they found 65% of their patients had a concomitant calculi. 18 of these patients had renograms, and 17 had a differential function of less than 10% preoperatively. When they compared open versus laparoscopic approach for XGP, they found that there was reduced blood loss in the lap group by about threefold. Transfusion rate, again, threefold less. Time to PO intake was 1 day less, and length of stay in hospital was about 3 to 4 times less as well. Interesting to note here that the initial diagnosis of XGP in the laparoscopic group had 4 patients that were identified initially as a renal mass, malignant process going on, 1 for polycystic kidney disease, and in the open group, 2 were thought to have retroperitoneal hemorrhage. So surgeons anticipating problems during the surgery tended to go for an open approach. With regards to the complications, there wasn't any real significant trend one way or the other which approach was better at preventing certain complications. It's likely due to the disease process itself and not the surgical approach that was taken, and it's sort of patient dependent and operator dependent as well. The case series is too small to really find any trends in that respect. This was a case series in 2012 that looked at 66 patients undergoing laparoscopic nephrectomy for XGP. They had 8 cases convert to open at a rate of 12.1%. Group 2 here is the open nephrectomy group, and group 1 is the partial nephrectomy group. Again, these investigators found similar results in that the blood loss was less, the surgical time was less, hospital stay was less in the partial nephrectomy, the laparoscopic nephrectomy group. So they were trying to figure out, is there any factors pre-op that we can use to determine which cases we need to just go straight to open for? And they found that the likelihood of converting to open was significantly increased in patients who had a longitudinal renal length of greater than 12 centimeters. So big kidney, big surgery. Right-sided nephrectomies were also more likely to go open or convert to open, probably due to the extensive inflammation and adhesion surrounding the big vessels, the vena cava, and easier exposure with an open nephrectomy approach. The third thing that they found was significant in relating conversion to open nephrectomy was increased time to isolating the renal vessels, which kind of makes sense. If you're having a tough time dissecting down on the renal hilum, then converting to an open approach will give you better visualization and aid in the progression of the surgery. This is a case series in 2006 where these investigators looked at whether or not open can be avoided if you're struggling with a laparoscopic approach. Just 11 patients over 3 years. Four of those 11 required a hand port placement for difficulty in progression, and they avoided any open nephrectomies during their time with those 4 cases. So low threshold to convert to a hand port, although if you're really struggling, then converting to open you won't be faulted for. This is a case that we had recently of XJP at St. Paul's Hospital. A 50-year-old gentleman. He had a past medical history of hepatitis C, HIV from a blood transfusion back in the 80s. He had florid cirrhosis and liver failure and factor VIII deficiency. He initially came to the hospital emergency department with a 10-day history of malaise and right flank pain, had some gross hematuria and worsening of his abdominal ascites. He had a significant leukocytosis, anemia, and bacteriuria, and it was staph, interestingly enough, not one that's commonly seen, and his blood cultures were negative at that time. He had a CT scan showing multiple stones in the intracalyceal region with dilatation, a subcapsular abscess measuring 8 by 5 by 11 centimeters, and a second perinephric collection at 10 by 5 by 14, tracking down the psoas and involving intimately the inferior vena cava. Here's a CT scan of this patient. You can see the right kidney there. Multiple stones within the collecting system, some dilatation here and parenchymal thinning with this perinephric abscess right here. Also can see some delayed uptake of contrast compared to the left kidney. Here again, this is just a little bit more inferior. This is that giant abscess that tracks down along the psoas and involves the IVC here. You can see just the lower pole of the kidney here, and it's a pretty significant abscess there. Here's a coronal shot, just showing the extent of the tracking down inferiorly. Quite extensive. So this gentleman underwent percutaneous, initially with fluid resuscitation and antibiotics, got percutaneous drainage of that perinephric abscess that was tracking down along the psoas, as well as a drain from his abdomen to take off some ascites to see whether that was contributing to his overall disease process. He did stabilize after the drainage of the abscess, which both drains, the abdominal ascites and the abscess, were actually sterile on culture, which is surprising. He was placed on prophylactic ciprofloxacin and had a nephrectomy 2 weeks later. He was seen in pre-anesthesia clinic about 4 or 5 days before he was supposed to go in for surgery, and he was a direct admit for fluid management because he was floridly edematous prior to his surgery, so came in for a tune-up under CTU, which was a blessing for us. Here's a shot of the perinephric abscess, which, well, is no longer present after the percutaneous drainage. So he actually had very good drainage from there and complete resolution of the abscess prior to him being discharged from hospital and going to the emergency nephrectomy, or sorry, the elective nephrectomy as an outpatient. Intraoperatively, he had dense adhesions around the kidney. There was quite a few kind of, it almost looked like those violin strings tying the kidney up to the peritoneum, like you'd see in a Fitzhugh-Curtis or those types of processes with stringy adhesions around. Quite an extensive dissection to get down over the renal vessels, but ultimately we were able to do it in a laparoscopic approach, and the patient actually did quite well. So we underwent a successful radical right nephrectomy, tolerated it well, recovered in pretty well routine MIS nephrectomy course, and he's unfortunately still being managed from his hepatic dysfunction, hemophilia, and HIV standpoint under the medical service currently. So, but the kidney came out okay. Transperitoneal, yeah. So with that's that. Happy to take any questions you guys have or anything. I'd like to thank Dr. Eng for letting me use his case and helping me through the XGP portion. Dr. Patterson for helping me pick a topic and guiding me through that, and to Dr. Batista de Costa for his input in his case that he let me kind of glean some information on in terms of management. So thanks guys for coming.